Few years ago, I did see a patient who has history of a bicuspid aortic valve. She's a 33-year-old woman who presented with chest pain and has a history of hypertension. Some of you who do echocardiography will recognize that this patient has severe aortic valve stenosis. She saw a surgeon who said, we'll have to proceed with valve replacement, and the cardiology team who saw her agreed with that. Before her surgery, they planned to do a coronary angiography because she has chest pain, she has a history of hypertension despite the young age. A coronary angiography was attempted from a femoral approach, and you can see with the catheter they could not cross the descending thoracic aorta. What did this patient have? Coarctation of the aorta, which is an association with bicuspid aortic valve. So the physicians taking care of the patients, knowing she has a bicuspid aortic valve, did not make that association that 7 to 10% of patients with bicuspid aortic valve will have coarctation, or that 50 or 70% of patients with coarctation will have a bicuspid valve. So when I was asked to speak about the dilemmas in patients with congenital aortic valve disease, and here I mean bicuspid valve, unicuspid valve, or quadricuspid aortic valve, I sat down, I thought, okay, what are the issues that are so important to keep in mind when you're managing those patients? Is it an isolated bicuspid valve, or there's an associated anomaly? What about the aortopathy, the dilated aorta that you see in 60% of those patients, and that affects what you are going to do, a TAVI, a Ross, or whatever surgery you want to do? What about the associated coronary artery anomalies or intracranial aneurysm? What about women who want to get pregnant and have a bicuspid aortic valve or a dilated aorta? That's a major concern, or don't want to be on warfarin. And screening all first-degree relatives or second-degree relatives. And finally, what's the ideal valve? You heard from Florencia, there's no ideal valve yet. But what are we going to do once we see these patients? Like all congenital heart disease, bicuspid aortic valve is often not a single lesion. You can see it with ASDs, VSDs, but more importantly, you see it with coarctation of the aorta, and that's so important when you're managing these patients. Why? Because if you have severe aortic stenosis and coarctation and you do a valve replacement, that surgeon is not going to be happy after surgery, because that patient is not going to do well with severe coarctation. When you have two successive stenosis, you always treat the distal stenosis first, then you come back and treat the proximal stenosis. And whenever you have coarctation in a patient with bicuspid valve, you have to think about syndromes like Schoen syndrome, which is successive obstruction on the left side, or Turner syndrome, which has peculiar features. And these patients, it's so important to identify them, because 1/3 of them will have the aortic dilatation, and they dissect at diameters of 40 millimeter. So you really want to know if it's syndromic or not. Intracranial aneurysm occurs in patients with bicuspid aortic valve at the rate of around 8 to 10%, similar to what we see with coarctation. Anomalous coronary artery also occurs in around 7% of these patients. So if you're doing a TAVI in a patient with a bicuspid valve and anomalous coronary artery, you can hurt that patient. In fact, when anomalous coronary arteries are not identified in patients with bicuspid aortic valve, they have postoperative coronary event more often than any others in a study of more than 1,000 patients. What about the risk of endocarditis? So bicuspid aortic valve is not a high risk, so you don't give SBE prophylaxis. That's the guidelines from 2007. But you know from this study from Spain, it's a registry of more than 7,000 consecutive endocarditis. Those with bicuspid aortic valve, as you can see on the right in blue, had a lot more complications and needed surgery similar to the high-risk patient, but we still don't give them SBA prophylaxis. Do they deserve SBA prophylaxis? Aortopathy is a major concern in patients with bicuspid aortic valve. 60% of patients with bicuspid aortic valve will have a dilated aorta. 25 of them will have an aortic root phenotype, which means the aortic root is enlarged, the sinuses, with effacement of the ST junction that looks like Marfan or Lewis-Leach syndrome or all those congenital aortopathies that dissect early. You also have involvement of the descending thoracic aorta in some of those patients. Something is very clear in my mind after seeing those patients for years. The risk of aortic dissection in a bicuspid aortic valve is higher than a general population, but nowhere close to patients with Marfan syndrome and Lewis-D syndrome. In a study that Dr. Hector Michelena from our institution did, it's a 25-year follow-up in Olmsted County. This is where the Mayo Clinic is in Rochester. So it's a community-based study. More than 400 patients with bicuspid aortic valve were followed over 25 years, 2 dissected. Only 2. So the risk is not that high, definitely. So what we do, meaning, if I have a bicuspid aortic valve and I do echo on my kids, mom and dad and brother and sister, and these are the first degree relatives, there's a 10% chance each one of them will have a bicuspid valve. But if they don't have a bicuspid valve and I do, there's up to 20 or 30% chance they can have a dilated aorta without having a bicuspid valve, especially if I have a dilated aorta. So you screen not only for bicuspid valve, but for thoracic aortic aneurysm. The dilemma is what to do and how often do you do it. I usually do an echo. That's a simpler technique, and I'm an echocardiographer. But at times, the aortic aneurysm occurs in the descending thoracic aorta. So I do it when we know, as well as do it before they start doing competitive athletes sports. And in women, I ask them to do it before they get pregnant. I only do genetic testing to look at mutation if they have syndrome, they look syndromic, they have other things that tell me it's a connective tissue disorder, or there are more than 2 individuals in the same family with dilated aorta, especially with the root involvement or the enlargement of the ST junction. Pregnancy is a big issue in young women. Thank God that men are not involved in this so far. So it's mainly in young women because we know there's an increased risk of aortic dissection in the presence of dilated aorta. We know the aorta grows up to 3 millimeters. One of the main reasons predominantly is estrogen. Estrogen interferes with collagen deposition in the connective tissue of the aorta. There's also a role for prolactin or oxytocin that's predominantly is estrogen. Unfortunately, the dissections occur not only during pregnancy, but after we dismiss the patients home postpartum in the descending thoracic aorta. There is no safe diameter to enabling pregnancy, but we know from the guidelines published, in fact, last year, if it is less than 40 millimeter in diameter, it's probably safe. The risk of dissection is less than 1%. If it's more than 50 millimeter or the diameter, index diameter more than 27, you probably should not get pregnant. Anything in between depends on so many variables, whether you have a family history of dissection, whether there's a growth over time, whether you have Turners, whether you have blood pressure changes, all of these are factors. Finally, what about the patient's valve replacement? What are you going to do? It depends on many things. These are the options for congenital aortopathies. If we do an aortic valve repair and patient has a bicuspid valve, non-calcified, young age, with aortic regurgitation and a pliable valve, you can do a tissue AVR, a mechanical AVR, a Ross procedure in somebody with AS and a small annulus without AR and without dilated aorta. You can do the Bantal procedure, which is a composite aortic valve and root if they have AS or AR and a dilated aorta, or a valve-sparing root replacement where you replace the root and the aorta but keep your own valve because the bicuspid valve can be functioning okay, or you can do TAVR. TAVR has been done in more than 1,000 patients with bicuspid valve. But as indicated by my colleagues, the two main risks with TAVR is that with the bicuspid valve, the annulus is ovoid, and you're putting a circular valve, so there's a higher risk for perivalvular aortic regurgitation. And unfortunately, there's up to 28% of heart block needing pacing, and that's a burden in a young adult. So there are many patient characteristics that are so important to be discussed by the heart team that has been mentioned, in addition the expertise at the center. So let's go back to my patients. This is the dilemmas, and this is the heart team discussion at that time. Her characteristics, she had AS with coarctation. She did not want to have pregnancies. She did not have an aortopathy or any sign of syndrome. She's not interested in high-level exercise activities. She has no comorbidities. And she said, I just want one operation and one operation only. I don't want to redo operation. Remember, if you do a tissue aortic valve replacement, the chances at 12 years to have another valve replacement is 25%. So, and if you do a Ross, you have two valves that you need to replace later on. Keeping in mind the expertise at the medical center is very important. So that's what we did with that patient. We did an ascending to descending aorta bypass through a mid-sternotomy and then the mechanical aortic valve replacement. We solved the two issues with the mid-sternotomy. So the take-home message, congenital aortic valve lesions are often not single lesions. You have to look for associated anomalies and syndrome. That creates a lot of dilemmas. A comprehensive assessment by the heart team, including experts with congenital aortic valve disease, is important. Otherwise, you might miss things like the missed coarctation in that patient. The ideal valve, unfortunately, doesn't exist yet, but at least we have many options as discussed earlier. At the end of the day, you have to do what's best for that patient, keeping in mind your expertise at the center. Thank you for your attention.